But people were driving slow in front of me for once. Usually they're pushing me, but they weren't today. We're going to talk about using the insulin pump. Sure. I am a registered nurse and I'm also a certified diabetes educator. And I would just plug my chapter meeting. I am also the president of the South Texas Diabetes Educators United. So if your nurses are interested in doing diabetes education, please feel free to let me know your email. I'm an email blast queen. And I know of all the nice dinner meetings, so it'd be great to see y'all there. Is it too late to put an elderly on an insulin pump? No, because I'm getting older, so I don't want to hear that it's too late. A 65-year-old has an 18-year life expectancy, so we still have a lot of years to go. And that gives you time to get into problems with your complications, the strokes. Now, they're going to have problems with strokes because insulin helps you use the fats of the blood. So if your sugars are high, usually your cholesterol, triglycerides, your LDL is too low, and your HDL is not high like we'd like for it to be. Okay? So you remember HDL is H for higher and happy. We want more of that. L is for lousy and less. So that's how I remember. So that's why they're more likely to have strokes. But my argument is if their blood sugars are out of control, not just because they have diabetes. So it's always the blood sugar control. The blindness, that also happens blood vessel damage from that sugar sticking to that mature red blood cell and making it very stiff and hard. And it's scraping and damaging the blood vessels of the eyes, which are very, very fragile. Now the weird thing about your eyes is it will form new vessels around the broken ones, but those are even more fragile. So they start clogging and forming new ones and a scar. Have you ever noticed someone when they have a real bad scar, it's stretched, they have that stretchness to it? Well, that is pulling the nerve off the back of the eye, and that could lead to blindness. Laser therapy will prevent you from getting blind. It will not improve your vision. So that's something you have to tell your patients, because your patients are always telling me, but I couldn't see any better, so I quit going. Well, laser therapy is to prevent blindness. It doesn't improve vision. So make sure you tell your patients about that. Nephropathy, again, the little fragile blood vessels of the kidney are damaged from the high blood sugar. So it's not diabetes that's causing the problems. It's the high blood sugars. Keep telling your patients that. I tell my patients who are newly diagnosed at any age, I tell them diabetes will make you healthier if you let it. You got to work at it like all of us need to. Diabetic or not, we need to continue those healthy lifestyles. So nephropathy is blood vessel damage to the vessels that filter the urine. We usually check the microalbuminuria first, and before if you see an BUN and creatinine elevated, we've already got some damage going on. But a microalbuminuria, it's a urine test. It's not a urinalysis. It's not in the protein of the urinalysis. This is called a microalbuminuria. That's how we can see if they're having some early problems with their kidneys. So this is something you want to maybe mention to your doctors to have that done on your patients, because they're elderly. As we get older, things start to slow down. And then the cardiovascular disease. Again, blood vessel damage to the blood vessels of the heart, and also plaque forming in those blood vessels. And the body likes to attack that inflammation. That's why they want you to have a baby aspirin a day. It prevents the body from attacking that inflammation and making it break off and then floating around and blocking the vessel. So cardiovascular disease, also if they have family history, they're real high risk for the same problem. So you want to make sure you're having them checked for that. Infections, bacteria love sugar. Okay, if you have a lot of sugar in the bloodstream, you're going to feed any infection. If you have a lot of sugar in the bloodstream, you're also slowing the flow of the blood. So the blood's not gushing through there, taking away the infection and bringing the cells to help them heal. And even cognitive dysfunction can happen, okay, if the blood sugars are left too high, too low. So that might be one of the reasons we have non-compliance. They're not thinking straight, you know, and the more you talk to them, it takes a long time to get them to kind of realize. So they may get more forgetful, they worry they have Alzheimer's, or things. But it's just that problem that their blood sugars have been running too high. So we need to do whatever we need to control them, but not too tight. You don't want your elderly patients' blood sugars in the 130 range, okay? They metabolize a lot slower than our younger people, so you want to keep them a little higher. Even some of my patients, I'll even say 200, 180s. It's still okay, right? It's not going to cause any major problems. So it could cause hypoglycemia. So now you have people passing out and falling, hitting their head, breaking their hips. Sometimes I've heard that elderlies will break their hip first and then fall. So make sure you're checking your calcium on your patients. Do they have a bone density done? Have they checked that to make sure that they're not having any calcium issues? Of course, that's going to affect their lifestyle. They have decreased renal function, so they take a little longer to get rid of stuff through their kidneys. Slowed hormone regulation and counter-regulatory regulation. So those hormones that cause your liver to release some stored sugar. When you have road rage, that's what that is. It's those hormones making you get a lot of sugar, making your liver release a lot of sugar, so you have energy to go after that person, or cut them off, or fight them, or stay away from them, So it's the fight or flight syndrome. Okay. They get dehydrated really easily. Okay. So water, if they're drinking too much water, they actually could flush out a lot of sodium. So you do want them to have some electrolyte drinks. My mother is a good example. When she feels bad, the first thing she's asking for is her G2. Get me some G2. I always feel better as soon as I get some Gatorade. Now realize the carbs in it. Gatorade has a lot of, the regular Gatorade has a lot of carbohydrates, a lot of sugar in it. But the G2 is the diet Gatorade. So a 32-ounce bottle can have like 20 grams of carbs, which is hardly nothing. It's not, and if I have someone who's mowing the lawn, raking the yard, I tell them, don't even count that. You're going to work it off. But make sure your patients are getting their electrolytes. Make sure they're eating their tray and not giving it to the family members. They like to do that, and they won't tell you, so you need to kind of ask. And they'll like to save food for later, so you're checking their blood sugar and they're high because they just nibbled on the orange for breakfast. So kind of make sure, what are they eating? Train your assistants, your family members, to kind of let you know if they ate or not. Slowed intestinal absorption, so they have slower intestinal absorption. So that's why you don't want to be as aggressive with their blood sugar control. They're on multiple medications, so steroids are ones that will make your patient's blood sugars go up high. Okay, so be aware of that. Not eating enough carbs, grazing, that's what I was talking about, skipping meals, not at risk, and put them at high risk for hypoglycemia. I used to have an x-ray guy, he was a transporter, and he loved to come get patients at lunchtime because he could find them in the room. But I gave a pre-lunch insulin dose, bolus, before the meal. And then they took them, and he didn't get to finish eating. So as soon as I realized, I grabbed the glucose meter, running to x-ray, and here comes Freddie here coming at me saying, your patient's having problems. I said, no, you took him. He didn't get to eat. So that taught me to teach my patient, I've given you insulin. You've got to eat this, this, and this. If you don't like the carbs, I point out the carbs, I need you to tell me so I can replace them with something else you feel like eating. And right then and there, a lot of my patients were telling me, I don't like the way that mashed potatoes look. I'm not going to eat them. Well, how about some graham crackers? Oh, okay, I want graham crackers. Same carbs. That's what the exchange system was. A carb is the same thing. We want them to have the healthy meal plan, so many fruits and vegetables. But the most important thing you want to make sure is that they're having their carbs. Which insulin regimen to use? The most difficult in prescribing an insulin regimen is for the clinicians to predict a peak of insulin, when it's going to peak. This not only depends on how much they're eating and how well they absorb it, but how active they do. If you have I have some patients that if you walk the mall, you got to move over to the side because they walk right by you. They'll push you out of their way. They're walking fast. And I have some that just barely get around with their walker. Okay. So it depends on how much activity they're doing. Miscalculating elderly patient insulin requirements may lead to a sharp, severe lowering of the blood sugar, and this is going to need emergency treatment. Okay, so they're going to pass out on you. They're going to have the sweats and the shakes. Very important. Anytime you start someone new on insulin or you give insulin, you want to make sure they know what to do if the sugar runs low. And they might even laugh and tell you, I've never had a low blood sugar. Well, they might now if we're getting them more strict control with the pump. We don't even start them at their usual dose. We give them 25% less of what their total daily dose is because the pumps work so well. And if you don't know how to manipulate a pump or program it, don't. Call the phone number on the back of the pump. They will walk you through it. They'll tell you what button to push. They'll tell you what information do you need, and they'll guide you. Okay? So always look on the back of the pump. You could even look on glucose meters. I tell my nurses, don't try to teach someone how to use a meter. One, it's going to make you look dumb, and two, it's too much time, okay, to teach them and read and look through the book and all that. Just have the patient call the phone number on the back of the meter, and they'll walk them through how to use it. Okay? So that's something, if you're ever wondering how to find out what's in that meter, the history, they call that number and they'll walk you through it. They're there 24/7. Also the insulin pumps. The company has someone answering the phones 24/7. So which insulin to use? Now we are using Humalog and Novolog in the pumps. So we're using the rapid-acting insulins. When I first started, we were using plain old regular, but then Novolog and Humalog came along. But if I have a patient who cannot afford it, which you guys don't have that problem here, you have coverage, that's awesome. Then I would have to use regular. I just kind of have to make some adjustments for that because it's a slower insulin. And insulin, Humalog and Novolog, it'll tell you that it starts like in 5 to 15 minutes. I tell my patients, give it 5 minutes before the meal if your numbers are okay, like 100, 120. I'll give it 5 minutes before the meal. But if they're running over 200, I have nurses waiting for the tray to get there and their sugars are 300. So I said, no, give that insulin. They can wait on in a half hour because they have enough push. They have enough sugar. So give that insulin so that it gets time to get absorbed and start bringing down the blood sugar. You want their blood sugars to be normal before they eat. So if they're too high, we use the sliding scale to bring it down. If they get a scheduled dose, we give that the 15 minutes prior to the meal to bring that sugar down to normal. And then you want to make sure they eat the carbs that they're supposed to have. So these new insulins match the insulin peaks of normal glycemic state and they get a patient to achieve better control. So they work a little better. But what I understand is the pancreas, when it functions the way it should, it uses up blood sugar in 2 minutes. So no matter what you ate, I put in a lot of health fairs at the mall, and the blood sugars are really high, and they say, oh, but I ate Luby's like 3 hours ago. Well, your pancreas should have made enough insulin to use that up. Okay. I had an orange Julius 3 hours ago. Your pancreas should have used that up. Okay. That's my lunch time. I have to make sure I eat. So it doesn't matter what they've eaten, their pancreas should have produced enough insulin to use up that sugar. Okay? So you'll have a lot of people, I drank a regular soda. Well, your pancreas should have produced enough insulin. They don't recommend to diagnose people with a meter. So when I do health fairs, I say anything over 140 is what I consider too high, especially if they're not fasting. If they're fasting and they're already at 140 and they have a family history, then I kind of give them a nudge that go get checked, just to make sure. There's no clinical guidelines as to when to intensify the medical therapy in the elderly. Each patient must be treated individually. So everybody's different. I have some patients that eat raisins. It doesn't do anything to their blood sugars. 2 tablespoons is a serving of carbs. It's 15 grams. And they won't do anything. I have others that have the amount they're supposed to, and they're high for 2 days. So there are certain foods that affect them more than they're supposed to. So there's really no guideline that tells you how to adjust it. But if it's roughly 200 despite maximum, that's fasting. So remember, we want fasting to be the lowest of the day. We don't recommend being at 200 fasting. Then the perennial values exceed this number with the resultant potential for significant hyperglycemia. And the injection agent should be used. So before the doctors really decide to put a patient on insulin, they want to find out the history. They don't want just blood sugar readings. They want to know, what are you eating? And a good friend of mine that works here, Barbara, she tells me a lot of the patients tell her that they don't eat, but they are drinking juice. So that is a carb. They don't realize that that does turn into sugar. And they don't have a meal, but then she finds out through the history, she's a good investigator, you know, knows how to interview patients. She can get the truth out of anybody. But that's one of the ways that I wanted to really be a detective, and this is the way I get to do that. You really kind of got to ask the right questions and don't ask in a defensive manner, because they get upset and they'll shut up. They won't tell you anything. So it's really like walking on eggshells to ask those questions. But you want to find out from your patients, what time are you eating? What time are you giving the dose? What did you do? What activities do you do? Because you have some people that garden, they walk their dog, and they're active. They might be using a walker, but they're still doing things. So that affects their blood sugar. So we need to know those things. These are the different types of insulin that are out there. And you'll notice that the regular insulin needs to be given a half hour before the meal. It needs a half hour to get absorbed. And all insulins will do this. They go up, they peak, and then they come down. It's a curve. Okay? And the NPH takes a little longer to work, and it peaks a little later, and it lasts a little longer. So that's why we would give it about every 12 hours. Anytime you have a drug that's twice a day, that means it lasts for 12 hours. If you have extended release medications, that's what they mean. That dose you're giving lasts all day. So that's why it's usually once a day. But you will notice that some of them that are supposed to be once a day, like your Lantus, they will give it twice a day because it doesn't last them 24 hours. So don't be surprised if you give once a day injection twice a day. It might not be an error, it just means that the doctor knows that it doesn't last them 24 hours like it's supposed to. And there's all the different strings. You can also go to websites, Google for the action. There are some places that they will even send you a card if you email me. It's a way to trick you to email me. But I will give you that website. Insulin and renal patients. Usually when they're in renal failure, their insulin requirements go down. But then you will have some that prove you wrong. So we need to go by monitoring. The monitoring is the only way you know how did that enchilada plate affect my blood sugar. Check the blood sugar 2 hours after. If it's tied 2 hours after, like less than 180, it's still okay. It's not a good choice because it's very high in fat, but it's not bothering your blood sugar. But 4 hours later, it should be down to in the elderly, we want them in the 180s. Maybe the 150s the lowest. If you really have someone who's brittle or hard to control, you want them a little higher than 150. And again, your doctor will let you know. And let your doctors know if you're having trouble with hypoglycemia and you know what the problem is. They have a poor appetite, okay? They just don't eat right. They are really going around the hospital, the lobby, the hallway. They're doing rounds. They're really active, okay? They need to know that. They need to know that the family's bringing in food. So do you guys have PCAs, right? You have nurse aides here? No? I have nurses, right? Okay. So we have PCAs. That's an important part of your team. And then whoever delivers the tray, if you can get them to let you know how much they ate, because the patient will tell you they ate all of it, and it turns out that it was a family. Okay? Or the family brings in food from outside. My husband had an uncle here that his aunt would bring him tortillas from home and the vermicelli, the casseroles that we make. And so his sugar's really high. Unfortunately, he had a lot of complications because she was forced by him to give him what he wanted. But hypoglycemia is one of the major problems that we have with anyone on insulin. You want to make sure they know that they have to eat so many grams of carbs per meal. They have to know how to take care of us. They have to know the signs and symptoms and the treatment of a low blood sugar. So that's the first thing you ever want to teach someone, that you're sending them home on insulin, okay, for the first time, or any oral agents that cause hypoglycemia. Your sulfonylureas, okay, so you want to make sure they know about hypoglycemia. And then also you want to make sure that they know that when to take their insulin. And sometimes the doctors doesn't want a sliding scale at night. And to make sure they know how to separate the two, I like to put the bedtime shot by the bedroom and not where the other one is, because that has happened. They picked up the wrong pin or bottle. So make sure they kind of separate them and know which one's the night one. I've even had to label at night and put tape over it with a marker and then tape it so it won't erase. All sorts of things, clues. Cloudy one is for bedtime, but now our bedtime insulins are clear. So you're going to have to kind of make sure. Patient and family education cannot be overemphasized. And being an educator, I really, any kind of education on not just diabetes, but everything should be taught to the patient. And a support person. They need someone. I always ask them, who's your cook? Who do you live with? Because a lot of times they don't show up. So I've done stuff over the phone. I've emailed information to them because they can't come in. But I want to make sure they get the information. So it's real important that you kind of find out who their support person is. And if they don't have one and they need one, we need to set them up with home health. Okay? Or maybe even get the social worker involved to get a provider for them. So maybe they need that. So they need to know how to do that. And I know you all have case managers and social workers. 32% of elderly patients receiving insulin had no knowledge regarding hypoglycemia. So some people will be started at the doctor's office and they're given the prescription and they hope they learn it. I mean, it's kind of really outrageous. So pharmacists will teach your patients, remind the patients that some of those companies like Lantus has a 24-hour helpline. They could call 24 hours a day to get help on how to use the pen, if that's what they're using. The pump, if they run into any problems with it, they always should call their trainer. So they need to have that information of who trained them. They need to have the doctor's information, who to call after hours. I even have them do an experiment. Go home and call your doctor's office after hours and see what the message says. And if you push 0, you usually get the answering service. But doctors don't want you to know that. But, you know, I want the safety for my patients, so I want to make sure they know. And the doctors will call the patients back. Yes, ma'am?
Is there a difference between, other than the dialing with the pen and the injectable, is the needle the same?
Very good question. The length of the needle has really been under research right now. The pumps use a 6-millimeter length needle. Some hospitals have 12-millimeter long needles. And if you have someone who this is all the fat they have on their stomach, you need to really make sure you're pinching up the fat. And in a pump also you want to make sure you're giving it. So they do recommend that there are some pen needles that are 4 millimeters. No matter how much that patient weighs, he can use that. So everybody's skin is 3 millimeters thick. But you can use a needle that is as little as 4 millimeters. That's the shortest you'll find. And the 32 gauge is the thinnest. But the insulin pump catheter is 6 millimeters. So on kids, you know, the elderly, you got also a lot of loose skin. So you want to make sure you're putting it where the tape is going to hold. You want to make sure you're putting it where there is some fat there, because they have a tendency to be a little looser. Their skin's a little looser and fragile. So make sure the tape's not irritating them. They'll tell you, but sometimes you have to always make sure. And you always want to look at your patients where they're giving insulin, and you'll see a hump. This is called what Dr. Schwartz used to call a sweet spot, because they like it. It doesn't hurt anymore. And they give their shots there. And they'll tell you, oh, yeah, I move a ½ inch. Yeah, but it's a 10-inch diameter. You know, they're just giving them here all the time. And that does hurt the absorption of the insulin. If they're using it in a place that does not absorb well, they're not going to get the effect of the insulin like they should. So the length of the needle does matter. If you have someone really skinny, you don't want to use a very long one. We heard a story of it. The child gave a shot with a long needle. He ended up hitting muscle, rode his bike to school, had recess, and then had a seizure there at the playground because that insulin got absorbed really fast. He ate, but it absorbed faster than what we needed it to. So the hypoglycemia is one of your biggest worries, so make sure you always cover that. The basal insulin, you should have 50% of your total daily dose of insulin should be basal, and the other 50% should be the bolus. There is a way to see that on the insulin pump, so again, you call the company and they'll tell you where to see how much they're getting. If they're having problems with hypoglycemia when they're not eating, that means the basal rate's too high. Basal insulin should not cause hypoglycemia if they don't eat. Be aware of that, like Lantus, Levemir. NPH could because it has a So the basal insulin is the first major advancement in the treatment of type 1s or type 2s. Has no significant peak. It can be administered at nearly at any time of the day, be it morning, noon, or evening, but you want them to be consistent. You don't want them to give it at night and then that morning decide, oh, I'm going to switch it to days, because they're going to run into each other. So they have to decide what time of the day and stick with that. It can't be changing it. And if they want to change it, then we need to help them with that. And a lot of times patients tell me, well, my bedtime's at 2 in the morning. We consider bedtime 4 hours after you've had supper. Okay? And 3 and 6 hours after they've gone to bed, we should have them check to make sure that bedtime dose is not too strong. And you want them to check that morning, that bedtime, during the night blood sugars 3 and 6 hours after going to bed, if you're waking up high. If they're waking up high, it could be for 2 different reasons. They could wake up high because they had a low blood sugar during the night. And during the night, they slept through that low, that trend that when it went down, but the liver took over and it produced a lot of sugar. So you can actually have a high fasting blood sugar because they were low during the night. I always ask them, did you have a nightmare? Did you just like, whoop, wake up? Did you go to the bathroom a lot? Usually if they go to the bathroom a lot, I'm pretty sure they were probably high. But if they woke up and they're all sweaty, they thought maybe the air conditioner stopped working or they just had a hot flash. The ladies will always tell me they had a hot flash. And you get ostracized with hot flashes because you put the covers off and you put them on. So you get a lot of exercise with hot flashes. But that basal insulin, you want to make sure you're checking that 3 and 6 hours after they go to bed to see if they're having some problems with their blood sugars, especially on the pumps. The pumps, the first time they go home, I tell them, I need you to check it 3 hours after you go to bed. And I go, don't call me with the results unless we're bad, unless you're having issues. But I set the alarm for 3 hours, and then we have them wake up. After the 3 hours, they set it for another 3 hours and wake up and check it just to make sure. And if it's questionable, like 100, I go ahead and snack them, just to kind of see. I don't want to take a chance. Because your elderly, remember, they go down on you really quick. They could go really low on you really fast. I'd rather be on the side of high blood sugars than a low blood sugars. They're in the middle of HEB and they have a low blood sugar symptoms. They think they're low. Go ahead and eat there. Tell them not to drive. They're dangerous as it is when they drive. We all are. But tell them not to drive when they feel bad, period. If they feel bad, they might think they're high, they might think they're low. I want them to go ahead and eat something. They should always carry glucose tablets with them or some kind of sugar, the gummy bears, the lifesavers. We don't recommend chocolate anymore, darn it. But chocolate has a lot of fat. It doesn't let you get the sugar right away. And they want you to have the skim milk for a low blood sugar. They want you to have the juice for a low blood sugar, regular soda, or any kind of regular juices is fine. But just about half a cup. If they feel real wicked low, they look like they're about to pass out on you, then I would give them 2 juices. I would double the treatment. Instead of just 15 grams, I would give them 30 grams. And make sure you check them because sometimes they'll go up to 100 on you and they'll go right back down. And they're calling you. And sometimes they tell me, I just can't eat anymore. So I show them the D50, boy, they can eat again. Once they see that big needle, it freaks them out. Because D50 has to be pushed pretty hard. It's very thick. So make sure your basal insulins, that the time of onset is 2 to 4 hours and the total duration is about 20 to 24. But you might find that there are some that it doesn't last as long. It has a lower chance of causing hypoglycemia, but it could if it's just too much for them. And the NPH causes more of a problem again because of that peak it has. You cannot mix Lantus with anything because the pH is real high. So never mix Lantus with any insulin. It has to be separate. Switching to Lantus, they recommend that you reduce the dosage by 20% when converting from basal insulin to insulin Lantus. But on your pumps, they will not have Lantus any longer. Okay, so just be aware there will be no more bedtime shot. So remind your patient not to take it. They should have been told by the trainer, but always reinforcing is also great. You know, they go, yes, you told me that already, or they told me that. So I want to make sure you know that. So no more bedtime shot. The insulin pump is going to deliver the same way. They will have an insulin to carb ratio on their pump. The pumps have a really nice calculator. The doctor's going to tell us what to program it with, and the trainer will do it, or the educator will program it for them. And the calculator on all pumps, it has an insulin to carb ratio. And so they've done a formula to figure that out. And the patient will put the B button, you guys use a Medtronic a lot. The B button is your bolus wizard. And it tells you enter blood sugar, you enter it with the arrows, and then you push activate to put that information into that calculator. And then the next question that's going to pop up is how many grams of carbs are they eating? So you're going to put that in with the arrows and you push activate, and then it'll tell you how much insulin they need, and it gives you the breakdown as to why they need that much. So it tells you, okay, you told me your blood sugar is 200, and you told me you're going to eat 60 grams of carbs, and then the insulin for the blood sugar is this much, the insulin for the carbs is this much, but you have this much insulin active. Active means that you have a dose that has not finished working on you. So you will put in a 200 blood sugar, but you're not eating, and it will tell you don't give insulin. And you're like, what? Because they still have some insulin on board. So the pumps prevent overlapping insulins. So that's a really good tool. It's a really neat tool. So they'll have the insulin to carb ratio. That means that they need 1 unit of insulin to use the amount of carbs that the doctor wrote that wants us to program. I have had some patients that take 1 unit for every gram of carbs. And I have had one that took 1 unit for every 54 grams of carbs. She was newly diagnosed type 1. But your type 2, your elderly patients, they will probably have a less aggressive. And your doctors need to know what they're eating, how many grams of carbs. So your elderly patients need to know carb counting. They need to know what book they should be carrying with them. If you have some of them that are techie, because some of them are, they can do apps on their cell phones. You could do apps on your cell phone for calorie counting to lose weight. So there's lots of apps out there. You need to keep me on time.
You're good.
Okay.
When you finish, we eat, so there's no rush.
Okay.
And you're ahead of time. So.
This is the formula that the doctors will use to decide. So they have to know how much your patient is taking. One of the endos I used to work for, they would have them write like 3 days worth of diaries or 5 days worth of diaries, what time they took insulin, how much they took. They want to know any symptoms they had. And usually they started them at 25% less of what they were taking. A lot of them would freak out, and a lot of them were right. We shouldn't have taken it away, but it's a safety thing. You don't know what this pump's going to do with them, so it's just a way to always make sure that they're not going to get too much insulin. And again, you tell them about the hypoglycemia. This is just a formula. I don't think I need to go over that with y'all. So for people who are unwilling to learn or just can't learn the carb counting, a small dose, 2 to 4 units, depending on weight, type of diabetes, and typical meals, or pre-prandial insulin can be prescribed. So some doctors will tell them, oh, just take 5 units before each meal with it, because they just can't learn the carb counting, but they need that basal. A basal rate, you can adjust the strength of insulin with the insulin pump. Or a syringe, you can't adjust it. I can't give them a 10th of a unit of insulin on a syringe. I could give a half unit, that's about as low as I can go. But a pump, I could do a half of a 10th of a unit of insulin. Okay? Even a quarter, so it's a quarter of a 10th of a unit of insulin. So we could give tiny, tiny amounts. But sometimes your doctors, they just have trouble. The patient can't understand the bolus wizard, so we'll do they push the button and it automatically programs a unit, and I tell them take a unit for every bag of chips you're taking, take a unit for every slice of bread. So that's just simple, and it's not as intensely as I would love to teach them, but it's a start. So it is possible to do that when you have patients that just have trouble with the carb count. But they really don't recommend putting someone who's not able to see. Yeah, I've done it where I've taught someone to feel for the buttons, but it's not recommended. So many Medtronic does not want you to teach someone who's not able to program those buttons. So advise them to check their sugar before and the 2 hours after to make sure that dose worked. And the correction factor might also benefit these patients, so if they know their sugar's high, they give an extra button push. And you can adjust that button push to half a unit, or 2 units. So there are ways to get around to give them what they need. Correction factor is basically your sliding scale. Ooh, hate sliding scale. Sliding scale is taking care, it's a Band-Aid. You let the patient's sugar get up high and now you're doing something about it. The argument I get from the doctors is they don't know how they're going to react to it, so let's do this just for a few days. And in my hospital, they see me walking towards them, it's just today. I won't let them on the sign because I've harassed them so many times. And I say, okay, but the correction factor is telling the pump, 1 unit drops this patient's sugar 50 points. So that's what this is. The doctor will decide how much this affects them by the formulas that they do. So there are patients that you need to give them 1 unit for every 10 milligrams per deciliter, they're over the target. So the pump's going to do that math for them. And the nighttime safety, it's important to caution the elderly patients and their families not to use the correction factor at bedtime because rapidly acting insulin, the Novolog and Humalog, the analogs, are associated with the peak concentration levels and they result in the blood sugar going low during the night. So it's advise the patients and their family to make a correction the following morning. So I'd rather they be a little high than take a chance of giving them a dose. But if it's really, really high, maybe there's something wrong with the site. Okay? We don't recommend they change their site and go to bed because I want to make sure that that works. So if you have 2 unexplained high blood sugars on your patients, it could be that that site is not working. If the pump's delivering it, it's going into the body, but when you take the tape off, you might notice that the catheter is laying on the skin. And I've seen it where it's taped all around, and when I untaped it, that catheter, they bent somehow, it lifted the catheter out of the body and it laid back on their skin. I have seen also where it's in them, but it's leaking. Okay? Sometimes they just have too much insulin in that site. Okay? If you have someone who takes a lot of insulin, they could even get cellulitis. They just get too much insulin in that tissue. But they want them to wait till the morning to do something about a high blood sugar. They don't want them to try to take care of it during the night. Sometimes you'll have doctors that say, well, at the sliding scale for nighttime, it's this one instead. The correction factor, I can change it, I can lower it or increase it for it's at different times of the day. So the doctors they need to know if you have a fear of that or that's been happening, so they can tell you what to change it to. So summary, a delicate balance and challenge is achieving the goal of glucose control in the elderly. You want them to be safe, you don't want them to have problems, hypoglycemia, anybody, no matter what age, should not be driving with hypoglycemia. So I kind of tell my pump patients, always check your blood sugar. And if you're going on long trips, always do a blood sugar check. Soon, there was mentioned at one of the meetings, they're going to have it where your car will check your blood sugar, will connect to your glucose monitor, and your sensor that you're wearing, and then it'll even tell you where the nearest restaurant's at. So it's kind of nice. I want that nice. But even though we've used many insulin-based regimens, have been used safely in the elderly, hypoglycemia is the major concern we have. The known risk factors for severe hypoglycemia at recent hospital discharge, advanced age, and polypharmacy, or the use of 5 or more prescriptions. So they kind of realize that, that tighter control, this makes them more risk factors for them to have that hypoglycemia. Punitive mechanisms, age-associated decrease in hepatic oxidative. In other words, their liver just doesn't put out the sugar as fast as they need it, and their kidneys are too slow. Okay, they're slower than they should be. Those who've had diabetes for many years may lose the epinephrine and glucagon response. They don't realize they're running low. And the family members will tell you before they even realize it. They look kind of dazed. They kind of look like they're daydreaming. They just have a weird blank expression. So most of your family members can kind of tell. So tell your family members if this is a new device for them, anything unusual, you know, they snapped at you and they had no reason to get mad at you. Or they're acting silly, they're almost acting like they're drunk. That could be that they're actually having a low blood sugar. Or you wake up at night and they're all sweaty, or they're waking up and you hear them walking around. Go check on them. Okay? Screaming because of a nightmare, that might be that they're having a low blood sugar. So you want to always have them, any unusual symptoms. And if you can, it'd be great to check the blood sugar to make sure that's what it is. Okay. I had a patient, he was younger, but he was really handsome. And he came up to us, and it was me and two other educators, and we were all flirting with him, you know, and he was telling us jokes, and we were laughing, and he was hitting the punchline. And his wife came up, she's kind of mean looking, and we felt bad already, guilty, because we were flirting with her husband, and she says, you know he's having a low blood sugar. We're like, what? And we ran, we scrambled because she scared us. And we checked his blood sugar, sure enough, he was 42. Yeah. But, you know, we were so enticed with his looks, but, you know, no sweats, no shakes, but he was really acting outgoing. And once we fed him, he was very shy, very, very shy. So that kind of made me realize that you never have the traditional hypoglycemia symptoms. So anything unusual. Your patient's usually real nice to you, and he yelled at you, and you're like, what was that about? Go check the blood sugar. It actually might be, you know what, let me check your blood sugar, make sure it's doing okay. You don't need you have an order to do your blood sugar monitoring. You can do as many as you want. You're worried about, well, they only ate about 50% of the carbs and they don't want to eat anymore. Check them again in an hour or two. Just make sure they're okay. Tell your patient, let me know if anything's wrong, you're feeling strange. The family members, any questions, give them resources. Make sure that the trainer gives them their phone number, so they have someone to call. Make sure your patient knows about those phone numbers on the back of the pump, so they can call anytime. They'll feel more comfortable, and hopefully they will use those resources. And they could go online and get classes. They also can meet with an educator in their hospital or doctor's office to help them learn more and more about the pump. You don't learn it in one visit. It has to be a lot of reinforcement. And then they have to try it out at home. You know, here in the hospital, we have a schedule. They bring you the food. At home, you have to cook it. You have to go buy it or whatever. So that affects them. So they need to realize that. Any questions?
Why would you put someone on a pump versus injection?
Because they can't handle the action of the syringe insulin. Because remember, once you give Lantus or Novolog or Humalog, it's going to work in half an hour, peak in 2 hours, last for 4 hours, and it might be too strong for them. So it might be that the action of the insulin injection, we need to adjust the strength of it. So that's a good reason. Hypoglycemia and hyperglycemia.
What about patients that are real unstable? You know, I had a patient once that had a monitor. He had a monitor that would monitor his blood sugar, and it would compare it to what his finger stick was, because he was such a fragile,
Brittle.
Very, very. And so he had extreme highs and extreme lows.
Yeah.
And so,
Well, the pump would be great for him because he's probably, was he on insulin injections? Or pump?
he was still able to do that, but somebody like that, I was gonna say.
They would need it. Yeah, yeah. I had a young girl who was newly diagnosed, and they go into remission with their diabetes. We call it the honeymoon phase. We regenerate the cells, the beta cells, once we start giving them insulin. She needed 5 units total all day. So if you gave her 5 units, she would pass out right in front of you. But she needed that trickle all day long. She's the one that would give 1 unit for every 54 grams of carbs. So everybody's different, how it affects them. But we need them to see a doctor who specializes in insulin pumps. I have a lot of primaries who are ordering pumps and have no idea how to adjust them. So you want to make sure you have your patient seeing an endocrinologist, someone who's knowledgeable about the pumps. Yes, ma'am.
From a financial standpoint, does Medicare approve the pump for these elderly?
Medicare does not approve the pumps unless your C-peptide is really low, but what I understand here at the VA, they don't, right? Yes, ma'am.
Yeah, Mary, the VA has pretty rigid policies on who is eligible for the pump, and they have to be a type
Awesome.
offered under the diabetes consult menu to have a patient referred to replacement of continuous glucose sensor. The pump issues are being closely supervised by the administration, and they are issued only to the diabetes.
And I always say the squeaky wheel gets the oil. So if they write to the congressman or VA administration, if they need it, it won't help. Huh?
This is a national, this is.
Oh, national, that's different.
Has recently, that there's been, with the issues that we're dealing with right
Wow.
now, there are a lot of complaints about this
Oh,
particular
great.
issue. But Washington has backed the policy that we're doing.
That's it. But outside of the VA, they have.
Comment, there's really no article, no clinical trial that shows in type 2s a pump provides better control than.
No,
than
it's
type
mostly your type 1s and someone who's like the elderly.
So we're not denying our patients good care.
But some of them would benefit from maybe a pump, but unfortunately they have to go with the coverage. And they can do it with we can do what we call a regimen of 4 shots a day. That's 3 shots of the fast-acting insulin and then the long-acting insulin at bedtime. Because some people, they can't get a pump, but we can do a regimen. We could even do insulin, the carb counting, correction factor, the same thing as the pump, but it won't be in the minute amounts.
Just one more question.
Mhm.
Can you share how much it costs? for-
Oh, I knew you were going to ask me that. They're $6,000, just a pump. And the supplies can run you about $200 a month. The insulin's cheaper, it comes in a bottle. And there's 1,000 units, it depends on how much you take, how much you use. Yeah. But a lot of the, it does give them the control they need, but we can do it with a 4-shot option. But they have to learn carb counting still too. They have to know how the insulin works, the action of the insulin. Yes,
I'd
ma'am?
like to point out that an ER visit's about $5,000 to $6,000. So
Yeah.
if you have a patient who's showing the ER over and over and over, it might be cheaper to put them on a pump and keep them out of emergency room.
I have skid marks to my office where patients, I don't want a pump, I don't want a pump. And then when we put them, we showed them about it, they wore it, they said, I should have done this a long time ago. But, it's just getting them. Any other questions? Y'all just want to eat. So I appreciate your attention.
No, thank you so much, Mary Reyes. Appreciate your time and for coming over during this horrendous weather we're having right now.
Well, you're going to feed me, go back.
Actually, no, we're not. We're going to
Not
have
yet.
another speaker. He's going to give 2 talks in a row, so lunch will be about an hour from now. Just kidding. Lunch is served in the back. Let's see, hold on. It is 11:45. We will start again at 12:45 because our next speaker, Dr. Blodgett, is here and present and accounted for. So at 11:45 we'll start. Okay, that's our next talk. So that's about an hour and 10 minutes. So come on back in about an hour.